Picture this. You're sick or your kid is injured and you call UCLA Health only to be placed on hold. You tried the website too, but you're not sure where to begin. Now, imagine you call and you're booked within seconds. No waiting, no guessing, just clarity. That contrast isn't about people, it's about access design. And that's our focus for today. We're a dream team. Ruchi, Mia, David, and I'm Elizabeth. And our dream for UCLA Health is smart, bold, and realistic. Our proposal focuses on two independent but complementary patient-facing operational workflows: an AI-enhanced call center and AI scheduling and appointment management. These are the front doors to the health system. They determine how patients experience care, how staff experience their work, and how well UCLA Health can deliver on its mission. Strengthening these two makes access intuitive for patients, sustainable for staff, and faithful to UCLA's high-touch model of healing humankind one patient at a time. We anchor our strategy around two goals. The first, human-led AI-assisted operations. The second, improved patient experience and access. That translates into using AI to focus on core operational workflows, specifically in high-impact, high-burden areas. Together, these goals support our vision, which is to position UCLA Health as the West Coast leader in AI-driven healthcare operations. To ground our strategy, we looked outside of healthcare at three industries already using AI. The first, legal, which teaches us to use AI for document and transcription workflows. The second, cybersecurity, which teaches us to use AI to detect operational threats. And the third, e-commerce, which teaches us to use AI to forecast and redistribute resources. The commonality is that AI is detecting, predicting, and accelerating operations, and that is the exact same model we apply to patient access, scheduling, and capacity at UCLA Health.
This slide summarizes our proposal one. On the left are three access channels communicating with each other: website assistant, text message, and call center, each designed to handle routine requests with escalation as needed. On the left are the outcome goals we are targeting with this proposal one. We are looking at abandonment rate reduced by less than 2%, improved patient self-service containment. We are trying to reduce average handle time and overall improve patient satisfaction score, allowing us to match demands without matching staffing needs. On the right bottom is our integration backbone. We are trying to integrate Epic EHR connected with customer relationship management and contact center as service platform in a HIPAA compliant environment. The key takeaway with this proposal is to add a single integrated access layer to improve performance and scalability without adding complexity. The first place to see this in action is at the front door, at the website. Let's begin with an example here. This is our patient going to our website, and he types, "Find a cardiologist near Westwood." Now this prompt stays on the website. The AI assistant filters the providers in the area, prompts to log in, schedules an appointment, and routes the request to the right queue, handing off securely to My UCLA Health. This platform can be used to address simple access questions associated with insurance, billing, provider scheduling, and frequently asked questions available 24/7 and in multiple languages. With this model, we aim to hit for 1.2 million in annual labor savings and 20 to 35% deflection rate, where website-originated inquiries are resolved without escalation. Simple questions remain simple and don't turn into calls is our goal. However, for interactions that require live assistance, our experience expands into our call center. Let's again begin with an example here. A patient calls UCLA and says, "I'm calling about a billing issue." Now our AI IVR will identify the intent, handle authentication, and route the request to the right queue. We also have an ability to use this AI IVR in helping our agents with the real-time information, knowledge surfacing, compliance prompts, and writing the audio summaries back into the Epic for future reference. Another model that we can look at with this proposal is for higher acuity patients. The call ahead conversations can be recorded, and the ED and the nurse can be notified regarding the ETA and chief complaint to better prepare the room to receive the patient, to rule out staffing needs, and to reduce bottlenecks. With this proposal, we are aiming for less than 2% abandonment rate, 3.5 million in annual labor saving, 25 to 35% reduced average handle time, and overall improving quality and compliance. For the fastest resolution, sometimes we don't require a call. And in that case, the friction drops the fastest at the level of text messaging. Now, with text messaging, we are looking at two-way SMS, which means a patient can reply to a reminder regarding an appointment. And let's say a patient types back saying, I need help rescheduling. In this case, the AI identifies the intent, looks for the slot, books the slots, sends a confirmation, updates it into Epic. All of this done without any staff involvement. With this model, we can utilize this to send reminders, schedule appointments, send educational content to the patient before the appointment, send marketing and surveys. With this model, our goal is at the bottom, you can see the ROI profile. We are looking at more than 1 million in annual labor saving and 400% return on investment by year 2. In the center bottom, you can look at the impact we are targeting. We are looking to reduce no-show response, reduce response time, call volume deflection by sending reminders and scheduling. And on the left bottom is the KPIs we are targeting, which is we'll keep a track of no-show rate, SMS engagement, reschedule turnaround, and containment rate. The goal here is a proactive approach to make access scalable, measurable, and sustainable.
We conducted an analysis of leading AI contact center vendors, evaluating them across our channel coverages, which includes the website virtual assistant, AI call center, and text messaging, and also evaluating them in terms of Epic integration and healthcare depth. Here are the top list of vendors. Each of them have their own strength, which we listed on the right-hand column, but our recommended vendor is at the top of our list, highlighted with the green icon, Core AI. The reason why we're choosing Core AI is because it has an omni-channel platform that connects all these proposed channels together and creates a seamless experience, and it also has Epic interoperability. Core AI is also used at large healthcare organizations today, like Kaiser Permanente and Pfizer, demonstrating both scalability and healthcare grade maturity. If we look at our roadmaps, they're designed to scale early or bring value early and build responsibly. Proposal 1's roadmap first starts off with our pilot. We begin with the website virtual assistants and contact center agents with interactive voice response, IVR. The primary focus of this phase is to confirm operational fit and also confirm adoption and performance. Phase 2 is where we scale, we add text automation, and also expand across all primary care lines. And lastly, phase 4 is where we optimize and modify these omni-channel experiences based off of staff and patient feedback.
Our second proposal here is an automated scheduling and appointment management system that integrates artificial intelligence into UCLA Health scheduling system. For a quick overview on this technology, machine learning predictive systems are able to integrate and analyze historic patient data, including demographic data, histories of past absences, and other variables to produce a unique risk score for each patient. High-risk patients are then able to be identified and proactively engaged to either confirm their arrival for the day or to schedule their appointment as needed. Our outcome goals for our second proposal on the right: first, and very importantly, we want to reduce the no-show rate by 20%. Second, we want to improve appointment utilization rate by 3 to 8%. And last, we want to reduce manual labor by 5 to 10%. This software will integrate into UCLA Health's EHR, registration, and referral systems. So why is Dream Team so interested in patient no-shows? They are a chronic issue across all health systems that are costing the U.S. Health industry about $150 billion annually. We can actually illustrate the costs of this issue using Ronald Reagan Medical Center as an example. First, the LA County Department of Health Services recently estimated the no-show rate to be around 20%. Industry research sets the cost for each patient no-show at around $200. With the annual patient volume here at Ronald Reagan at around 607,000 patients per year, we can actually estimate the total cost here at Ronald Reagan Medical Center. So we estimate that UCLA Ronald Reagan Medical Center is losing about $24,280,000 per year solely due to patient no-shows. Dream Team is really excited about the power of predictive models. Current systems are very powerful and only getting more sophisticated. We envision in the next year for predictive models to be integrated across all departments, across all health systems. Select models that we're looking at are able to predict all appointments about 93% of the time and all patient no-shows about 80% of the time. If we account for this information and proactively use it, research shows that we can save about 20%. We can actually reduce the no-show rate by about 20%. So if we go back to our figure at the bottom and account for those savings, UCLA Ronald Reagan Medical Center is poised to save about $4,856,000 annually if we implement such systems.
Our roadmap for Proposal 2 is broken out into 4 phases, each spanning a year. The first phase is the pilot. So this is where we align all key groups and deploy in a select department, of course, with oversight to confirm operational fit. In the next phase is where we scale. We expand the range of patient data and introduce no-show prediction. The primary focus of this phase is on change management and training. Phase 3 is where we optimize and expand enterprise-wide and also integrate with existing systems, which leads us to phase 4, continuous process improvement and long-term value realization, where KPI performance leads to targeted investments. Now, here's a summarization of everything that we discussed. Proposal 1, Proposal 2 is our breakdown, and the reason why we're discussing these proposals together is to show the value that each of these channels bring on their own. They can work independently, but are intended to work together and are stronger together. This is meaningful because it shows where automation delivers the greatest improvements in a personalized patient care.
We created an implementation plan that ensures AI is adopted and not imposed. On the left in blue, we have our foundation, like governance, understanding our current state, and define problems. We also move on to an execution and sustainability phase where we're really looking at it from a bird's eye view of implementation, integration, and expanding. We considered AI use for revenue cycle management. However, given our focus of access for this proposal, we rejected it and we recommend it as a future phase initiative. Our guiding principle is simple. AI is the tool, people are the purpose. A human-led AI-assisted approach allows us to reduce friction and automate routine work while people remain accountable. This is how UCLA Health leads the next era of operational excellence. Thank you. We're happy to take your questions.
All right, great work. A lot of really good ideas in there. So thanks for sharing. I liked how you guys started with real world problems that we're actually trying to solve today. So that was very relevant. As we think about the next 5 years after this, what are some other ideas that you guys talked about in the next 5 years? Because AI is going to bring a lot of new things. And so I think the call center and the scheduling is good, but what else besides that?
Yeah, I could speak a little bit on that. I think one of our first interests when looking at these two proposals was looking at the AI foundation that UCLA Health was already placing. We think that both of these proposals kind of plug in after we're able to build that strong foundation. For example, we were specifically focused on patient experience for both of these proposals, but UCLA Health is already pushing a lot of clinical AI. So we pretty much envision widespread throughout the whole health system, revenue cycle, patient experience, clinical will be a big area in the future.
Okay, I'll chime in. Great presentation, guys. Some comments or some thoughts that come to mind. You called out how UCLA would be on its way to being the West Coast leader. I think within our leadership team, we like to think of ourselves as a national leader or a world leader. So, so you can aim higher. It's okay. Don't be shy. Another thing that just stuck out to me was it's interesting that you called out that the revenue cycle is an area not to focus on right now. If you read the literature, you would think that that's the first area to jump at. But just with my colleagues here, we're finding that there's far more excitement outside the rev cycle, which is interesting. And a lot of our efforts are drawn to that. So you predicted that well. You must have used a cool machine learning model for that. This one's a little question for you. You called out the term predictive ML on your slides. In your mind, are you including generative AI with that or versus classic predictive machine learning? It's kind of a semantic thing, but just wanted to see where your head was at there.
Yeah, I could speak on that. I think we're thinking of classic machine learning. We're really interested in getting into an ideal state where we're able to integrate all patient data across the health system, find trends on information that's already available, and kind of focus on what other variables we could pick up on. So that's where we're headed.
I do want to add, the machine learning is also focused on being more humanistic. So we want these interactions to be thoughtful of the patient and not just on like workflow. It's truly, as we said, the front doors of patient care.
Okay. And next question was interesting on your slide. You called out a loss in FTEs, like that was a savings opportunity. I saw number 10 and 35 and stuff. Do you see any opportunities to retrain that workforce to do something else in the system as opposed to letting that headcount drop?
Yeah, I can speak a little bit on that. That is a huge consideration across the healthcare industry. We're thinking about such a disruptive technology that's going to create a new paradigm shift, but we believe that the strategy of UCLA Health and any health system is to retain and reskill as many employees as possible. So we're thinking about these proposals. We're thinking about change management, how that's going to look like, and giving employees opportunity for longevity here in the health system.
Okay, cool.
I would also like to add to that. We believe UCLA is growing and it will continue to grow. And we have a lot of opportunity to utilize the same man force to reach the goals that we desire to. So.
Thank you.
I'll ask one last question. I wanted to go to the proposal back to the predictive model for no-shows. So that's somewhat long established. Even Epic had a model a few years ago about no-show prediction. And so I'm wondering, we can probably build something that's excellent for flagging likelihood of showing up for your clinic visit, but the harder part is making sure they're like rescheduled or seeing what their needs are to get into their visit, what have you. So I think what I'm looking at the slides, you were a little light on that. So can you explain that part of things? Like how are you going to, help those patients reschedule or help them get to their visit on time? And maybe you don't even have to reschedule.
Yeah, definitely. It's another big consideration. We're envisioning this software to bolster the current human workforce. So to walk you through, when this risk score is generated, it could be used in different channels, either used automatically for double scheduling, for example, or putting patients on the wait list. But we are really interested in how these technologies can reduce manual labor. So the specific workflow that we're envisioning is using these risk scores to help schedulers, human schedulers, outline which patients are high risk and likely not to show. And then we're thinking phone calls from your providers, specific outreach, whether they need transportation, but really kind of giving people a chance to zero in.
And I do want to provide more insight. That was some of the considerations in our research. Of course, text messaging, website, and call center is how we're going to push and reach out to these patients, but it's also highly customizable, and that's the importance. Our research focused on patients who had different language complications that were more likely to show up when we understood their background, understood their language, and had like a more understanding of their healthcare system as a whole. So we would definitely want to integrate a piece of that and some of the research that we found.